Hello, my name is Terry Cunningham. I'm the president of the Liver Coalition of San Diego, and welcome to another informational seminar dealing with liver disease. Today, Dr. Robert Gish will be talking about viral hepatitis in pregnancy, and we have a lot of experts providing us with great information, and it's all available on our website for the Liver Coalition. So please take a look and see if there are any other topics that are of interest to you. And there's also a lot of very good other informational messages going on. We started the Liver Coalition last year to fill a void created during the pandemic. And now all funds raised here in San Diego stay in San Diego, unlike with other national organizations. So I want to thank you so much for attending this webinar. And again, please check our website for information on other webinars that have already been created. We have several sponsors who make this possible. And I'd like to start off by thanking Isai, and they have a video that we'll be showing right now. So much for that advertisement. And now we're going to go on to AbbVie, and they also have a video. And thank you, AbbVie, very much for your support. And now Greg Nolan from Gilead will say a few words.
Thank you, Terry, and thank you, Scott. Thank you, Liver Foundation, Liver Coalition for hosting this event. And certainly thank you to Dr. Bob Gish, world-renowned speaker, to do a great topic for us tonight. Thank you.
And we also have Carl Balzanti from Dynavax. So Carl, if you'd like to say a few words, please.
Sure, thank you, Terry, and I appreciate you pronouncing my last name perfectly. I wanted to thank you, Liver Coalition of San Diego. You guys do such great work, and it really is a pleasure to be a supporter of an organization that really does support the liver community in San Diego. Thank you, Dr. Gish, for making time for presenting tonight. Some of you may not know about Dynavax. We're a fairly new company that has come out with a brand new 2-dose, 1-month hepatitis B vaccine. There is no cure for hepatitis B, so vaccinations become very, very important when you're talking about Hep B. And at Dynavax, we have seen that a 2-dose, 1-month really fills a need. And so it's just really enjoyable to be able to be on this webinar, to listen to Dr. Gish. And thank you again, Scott, Terry, for all the great work you do.
Thank you very much. And thanks to all of our sponsors. We really appreciate it. We couldn't do this without you. So again, a big thanks to all of our sponsors. And now I'm going to turn it over to our moderator, Shirley Tsunoda, who is with the UCSD Skaggs School of Pharmacy and Pharmaceutical Sciences. And she's also the co-chair of our Associate Medical Advisory Council. So Shirley, please take over.
Thank you, Terry. So I'd just like to again introduce our speaker for tonight. The topic is liver disorders in pregnancy, a focus on viral hepatitis. And we have the eminent Dr. Bob Gish here to speak with us on this very important topic. And Dr. Gish is the principal of Robert G. Gish Consultants, LLC, among other many titles. Dr. Gish?
Thanks. Thank you, Shirley. Thanks for having me here. And it says share my webcam, which is time. So you can, little image superimposed here. Hopefully it's on the left or right side of your screen. Good evening, everybody. Thanks everybody for that great introduction. It's great to hear from Dynavax, ASI, Gilead, AbbVie, great supporters of our regional effort. And I'm really watching great collaborations take place through California and Nevada. So I'm very excited to be part of this. My practice encompasses both of those states, and I'm working heavily in Northern California, Southern California, Las Vegas, and Reno with different activities. So it's great to be here, great to be part of this evolution. I guess it's the upside of the pandemic. There's a lot to talk about in liver disorders in pregnancy. So we really decided to focus on viral hepatitis here because there's so many other things to talk about to make pregnancy possible, to make pregnancy safe. Let's see if I can get my slides to go forward. There we go. So viral hepatitis is actually the most common cause of jaundice in pregnancy, acute liver disease, also acute on chronic potentially. There is an increased risk of transmission of hepatitis A and B during delivery. I'm not going to talk a lot about hepatitis A during this presentation. I'm really going to focus on B, C, a little bit on E, and mention also herpes in this setting. Of course, we really are thinking about knowing everybody's hepatitis A status as adults and vaccinating everybody or everybody who's not exposed or immune. Really important to think about that. We're going to talk about hepatitis C transmission also. Hepatitis E, which is a global problem, not a really big problem in the US, but I think everybody needs to know about that. So we're going to talk about how to recognize liver disease in pregnancy, what liver diseases are unique to pregnancy, and what about special management techniques. We had a number of people, including Kim Brown, Miriam Levy, Tanya Kushner, who helped with the publications that I looked at and also slides that are part of this. I went forward a little too fast. I want to remind everybody that AST, ALT, alkaline phosphatase, and GGT are not liver function tests. Please enter the new period of our lives where we're talking about this accurately. This is even something I read about. The ACG has come out with a statement about this new terminology, and I hope the AASLD and AHGA and international organizations will join us. Liver function means bilirubin, albumin, INR, which is a coagulation test. So this is the terminology I'll be using throughout this presentation. So liver disease in pregnancy, you can look at, well, you know, Terry, Shirley, the rest of the team, you should really be thinking about a number of other presentations about liver disease in pregnancy over the next year. You see many other things I could be talking about, but we're going to be really focusing on viral hepatitis. So think about pregnancy as pre-pregnancy, first, second, and third trimester. This viral hepatitis issue can take place obviously pre-pregnancy. That's when every pregnant individual needs to be tested for viral hepatitis. And then you need to think about acute events during that first, second, and third. So if the liver enzymes increase, the patient develops abnormal function, that a full workup needs to take place, including viral hepatitis. And I'll talk about those tests in just a little bit. There's other diseases, hyperemesis gravidarum, intrahepatic cholestasis of pregnancy. preeclampsia, and something called HELP syndrome. Acute fatty liver pregnancy can be quite late in that 3rd trimester. So physiologic changes take place in pregnancy. Albumin and hemoglobin drop. This is really heavily focused on dilutional. There's a lot of extra fluid in the body. Liver enzymes can go up slightly during pregnancy, especially if there's, say, pre-existing fatty liver. But bilirubin, INR really shouldn't change. GGT shouldn't change. Bile acids shouldn't change unless there's a pathologic process. We don't check alpha fetoprotein during pregnancy because it's typically very, very high, and it's no longer a risk marker for liver cancer in that setting. And it takes 3 to 4 months after delivery for the alpha fetoprotein to go back into the normal and healthy range. Alkaline phosphatase can be high during pregnancy because of bone turnover, and as that fetus develops, the placenta also can make alkaline phosphatase. Any abnormalities in enzymes or bilirubin requires further evaluation, including workup for viral hepatitis. You can see from this pie graph that there's a lot of liver disorders of pregnancy. There's hepatic disease in the hospitalized pregnant individual, but go up to the upper right-hand side. About 15% of these individuals who are in the hospital for liver problems can have hepatitis B or C. On the right side is gallbladder disease, cholelithiasis, also that always has to be in. You still need to do a workup for alcohol, although fortunately alcohol is relatively rare in this setting as a form or cause of liver disease. So we work up liver tests. We're going to think of what's the pattern. Is it AST and ALT dominant? Is it alkaline phosphatase and GGT dominant? If it's GGT, it's biliary. If it's AST and ALT, we think of this as hepatocellular. It's that hepatocellular pattern that's typical for viral hepatitis. So we're going to focus on viral hepatitis, but any individual, including pregnancy, presents with liver disease, we have to do a workup for portal hypertension. We measure the spleen size, the portal vein diameter, look for a history of elevated liver tests, take a good thorough history about alcohol intake, metabolic syndrome. Hepatitis C, HIV, and hepatitis B, our advocacy is to test all pregnancies for all 3 of these viral diseases. And if you test during the prepartum, the pre-pregnancy interval, or right when pregnancy is identified, you can identify pre-existing disease and do an appropriate workup. Look at the platelet count, look at liver enzymes, the pattern of enzymes. Consider a fibroscan or an elastography test. We have multiple forms of elastography now, not just FibroScan, something called Velicure, Siemens, Philips, GE all have add-ons to measure liver stiffness, and a number of these devices can measure liver fat. Let's now talk about hepatitis B, since this is the most common type of chronic viral hepatitis globally, and in some settings, acute viral hepatitis. This is a special DNA virus that's similar to HIV, which is a retrovirus, which means it can make copies of itself and also integrate virus into the genome. It makes something called surface antigen, and of course, in response to that surface antibody and core antibody, we also can measure DNA, the level of the virus in the blood, and that helps us with infectivity. Hepatitis B is transmitted blood to blood. It's not by handshakes, kissing, hugging, spoons, glasses, salad bowls. So this is really a blood to blood, so it includes sexual transmission and of course mother to baby transmission. Mother to baby is the most common type of hepatitis B transmission in the world, although it makes up about half. For the other 50% could be a variety of different forms of blood exposure. When we talk about hepatitis B, we talk about drawing blood tests, and the best tests are surface antigen, core antibody, and surface antibody, which is what the bottom should say. It says surface antigen again. It should say surface antibody there. And you can quantify antibody and you can quantify antigen. Now, when I'm working up a patient for hepatitis B, including pregnancy, everybody is supposed to get this triple panel. Surface antigen is what says somebody has infection. It could be acute or chronic. The total core antibody equals exposure, but in acute hepatitis B, which can occur during pregnancy, IgM will be positive. It's a good test, it's not perfect. A core antibody means exposure. This test has a false positive rate of 2 per 1,000, so we don't talk about false positives anymore. If you see a core antibody, it means that person has some virus somewhere in their body. and then you match it up with surface antibody. Surface antibody only means immunity if the core antibody is negative. If you have core and surface together in a pregnant individual, that means that there's immune control, that the virus is being managed by the immune system, suppressed, and there'll be minimal virus, although the virus can reactivate in that pregnancy setting. There's no such thing as natural immunity. We don't boost people who are core antibody positive. And if people are triple negative, they need vaccine. And you heard already from our colleague at Dynavax that we have this new excellent high response rate vaccine with 2 doses. And 2 doses means better adherence, better compliance. You're going to finish 2 doses much more likely than you're going to finish 3 doses, which is the standard with the other 2 vaccines that are on the market. Of course, there's combination vaccines that we're going to offer to the newborn that we'll talk about a little bit later. We quantify virus in every individual who has hepatitis B surface antigen. This is very important in the pregnant mother because a high level of virus means that the mother needs to be on one of the 2 hepatitis B products that are made by Gilead. One is TDF, that's Viriad. The other is TAF, that's Vemlidy. And I'm going to give you these names now, but we're going to talk more about them a little bit later. Now, I'm not going to go through this slide because it's pretty complicated, but every individual who has hepatitis B is in one of these 4 phases, and there's actually a total of 6 phases, but we're going to just talk about 4 here during that viral replication phase. So that mother who's pregnant needs to be worked up and figure out what phase that hepatitis B is by looking at enzymes, looking at DNA, looking at E antigen, looking at E antibody. We can quantitate the S antigen also to help with this phase or decision making. Now, let's think about hepatitis B. There's this silent phase, or hepatitis B, it's not doing any harm necessarily to the individual, but it's doing harm to society because hepatitis B can be transmitted. This is an infectious disease during this silent phase. And it is silent, or sometimes we say sleeping, but every individual has to be monitored lifelong with a liver panel, with DNA assessment, and then getting into imaging of the liver cancer surveillance at the right time. The damage phase is evident when the liver enzymes, the ALT, rises, and normal and healthy means above 25 in a woman and above 35 in a man. Laboratories often give you different varieties of levels for ALT, but take home the 25-35 rule. Then there's back to this viral control phase, and this can happen because we're giving the patient one of our 3 different hepatitis B oral medicines. We don't use interferon too much in the United States. It's another way of trying to attain immune control. And you're going to monitor liver enzymes and liver function in those patients. Immune control actually has 2 meanings. If the patient's surface antigen positive, it means that the DNA is undetectable and the liver enzymes are normal. If the S antigen is negative, immune control means the surface antibody is positive in the setting of core antibody. So silent damage control, but of course, part of this is escape, and that means that that person can then start progressing again, develop the risk of liver cancer, have liver cancer, liver failure, transplant, and potentially dying. And that pregnant individual needs to be established what phase they're in, what are their enzymes, what's their function, do they have cirrhosis. Imaging, you can do an ultrasound during pregnancy of the liver, ultrasound of the liver during pregnancy, just like you can do an ultrasound and look at the fetus in the uterus. Control with medicine, we just mentioned TDF, TAF, there's a 3rd medicine, and Tenofovir, which we don't use during pregnancy. These can normalize enzymes, can normalize or negative, make the DNA go undetectable, and occasionally they can lose surface antigen and have something called a functional cure. Now, hepatitis B is never gone. So even though it says B is gone, we're going to say one of the blood tests is negative, meaning surface antigen is gone from the blood, but an individual with hepatitis B is going to have B in their liver lifelong. Now let's talk about this mother-to-child transmission. This is a very important issue. Hepatitis B among women of childbearing age. This is Quest data that Tanya Kushner published. there's over 8 million women who had hepatitis B testing during that period. So that means somebody's doing a good job, because this is the 15 to 44 window when pregnancy is there. And it could be with planning, it could be during pregnancies. And you're looking about some of the different states. But look at the national numbers. This is quite encouraging about this fall in the prevalence of hepatitis B during that time. Now, around 2017, I'm not going to show a slide here on this issue, but hepatitis B started going up just a tiny bit because of the opioid epidemic. We don't have data here after 2017, but you're starting to see just a little bit of a hint. In this, one of the states they looked at here was Indiana. So acute hepatitis B going up, IV drug use, needle sharing, and then some also risk of sexual transmission. So half of the hepatitis B in the world, that's their 292 million people, have hepatitis B that are surface antigen positive. Half of those individuals acquired hepatitis B from their mother. If the baby gets hepatitis B and isn't protected with vaccine or immune globulin, that baby, 90% chance that baby's going to develop chronic hepatitis B and be surface antigen positive for most of their life. Of those infants born with hepatitis B, we quote 20% are going to get liver failure, liver cancer, need a transplant, or die. It's a very big number, and it's probably higher now because of fatty liver and because of alcohol use. If we give the baby vaccine within 12 hours of birth and immune globulin, we can take that transmission rate down 90%. If we give the mother Tenofovir during the 3rd trimester, lowering the viral load, making the mom less infectious, we can take that risk of transmission down to 98% lower, get it down close to 0. So there is transmission that does take place across the uterus, but we think this is relatively small or relatively unimportant. It's that transmission during delivery, just after delivery, where hepatitis B can be acquired by that baby. Here are the 3 steps. Just going to talk about these again. You're going to give the mother a tenofovir derivative during the 3rd trimester if the viral load's over 200,000. You're going to give the baby vaccine. And a recent paper said really the vaccine should be given within 2 hours of birth. This is a very interesting study from Thailand that took place that said if we give that vaccine that early, we can cut transmission, and we may not even need that tenofovir derivative during the 3rd trimester, because a lot of times we don't know the mom's pregnant, we don't have the virus level in the mother. So getting that vaccine in earlier will partner with HBsAg, and maybe even don't need HBsAg in certain babies. So we're going to screen all pregnancies. Why? Because all of our other steps failed. In 2021, we're testing all pregnancies. And what you're going to hear about soon, I hope, is a harmonization in the United States to test all adults for hepatitis B, and for people who are triple negative, to vaccinate all adults for hepatitis B. This is the only way we're going to get to elimination. CDC is partnering in this with the ACIP. Right, screen all pregnant women. And it's kind of funny they say pregnant women. It should just say pregnancies, because only women can get pregnant. It's a little bit redundant. We're going to be checking DNA levels if the mother is surface antigen positive. We talked about vaccine and HBsAg. This universal vaccination process takes place. And there's a catch-up. Unvaccinated children, less than 19 years of age, should have routine vaccination as well. Then there's going to be hopefully a statement very soon about test all and vaccinate all who are triple negative. How do we prevent this transmission? Well, we talked about this, so I'm going to move quickly through this, although there's a lot of detail in this slide about how to prevent that transmission. Now, if the mother is surface antigen negative, you can vaccinate during pregnancy. This is very much actually a recommendation that takes place. And you can do it based on risk, but pretty soon we're going to say vaccinate all adults, and these vaccines do not pose a risk to the baby. So definitely going to discuss that vaccine process during pregnancy if the mother is triple negative. So we talked about 200,000, the viral load's over 200,000 international units. Third trimester, we're talking about giving this tenofovir-like derivative. And that 200,000 is really, I think, a very solid number. It also appears that this can decrease the risk of intrauterine fetal infection by decreasing that viral load. This is a Society for Maternal Fetal Medicine that came up with this. Talk about starting that therapy around 28 weeks of gestation. So you're going to notify the mother of the S antigen status, educate her, check the partner, talk about checking the whole family. And you should be having this mother managed by a hepatitis B specialist. That could be primary care, infectious disease, gastroenterology, hepatology. There's a lot of really good primary care providers out there that know about hepatitis B management. So you've got this 200,000 number you're going to take home, over 200,000 TDF starting at 28 weeks. You can stop it at the time of birth, or you can continue it after you give the mother informed consent, depending on her liver disease status, because there is this risk of flares. Now, what if the mother comes in, has never been tested for hepatitis B, and she's in the middle of delivering? Well, usually you can get that hepatitis B surface antigen result back within a few hours. But if the baby is really, really small, you can give the vaccine in HBsAg while you're waiting for that surface antigen result to come back. So this should be on a case by case. The baby's larger, you can just give that vaccine. And I mentioned giving that vaccine within 2 hours of birth. That is my current recommendation based on the Jourdain article in New England Journal of Medicine from, I think, a very good study that was done in Thailand. Now, a lot of things happen. I see when I get a hepatitis B test panel back, a lot of times it's just the surface antigen and core antibody IgM. I think that is terrible. It's almost worthless. So I've been working with Quest and a lot of other labs to really push people towards the chronic panel. So you're going to get a C antibody and you're going to get that triple hepatitis B panel that we talked about earlier. Then you work through the rest of the algorithm based on the C status and the triple panel that we talked about. This again is post-exposure prophylaxis. It talks about within 12 hours, I'm going to say 2 hours. The second dose is 1 to 2 months. And when you're doing the third dose, which is 24 weeks or 6 months, this triple vaccination that we're talking about is going to typically be done with Engerix-B or Recombavax, because those are the ones that are approved for birth doses and neonate infant vaccination. So I think we've gone over everything here. Testing you can do in the offspring of a mother who's known to be hepatitis B positive. Usually you're going to wait to check that baby's hepatitis B status around 9 to 12 months. You don't want to check core antibody in the baby until after 18 months because the core is transmitted by the mother transplacentally, and the baby can have core antibody for up to 18 months from the mother. You're going to report all of these surface antigen positive results to the Department of Health. There's a vaccine reporting process that takes place as well in many, many communities. Maybe Terry can comment at that at the end about San Diego. A little bit more on antiviral therapy, but the antiviral therapy during pregnancy may also be used to prevent flares. So let's say the mother's having a flare of her hepatitis B during the pregnancy. You may want to institute TDF, tenofovir-based therapy during that time. But it's very, very clear that these medicines work well, and you can get the HBV DNA, that level of virus, undetectable in patients quite quickly. This is very, very clear information that if the mother follows the protocol with this tenofovir-based therapy, you can take transmission down to 0. Very, very good. This is Calvin Pan, based in New York, but this is a study that he did prospectively in China. It's really, really an excellent study and deserves incredible attention. This goes back to why we're so active, because if the baby gets hepatitis B, they're going to have surface antigen for most of their life. If an adult gets hepatitis B from high-risk behavior, say sexual exposure, needle exposure, maybe medical exposure, medical care outside the United States, the chance of them having chronic hepatitis B is only 4%. So from 90% to 4%. So we're really, to get to elimination of hepatitis B, we really got to work to block this mother-to-baby transmission. The mother also is going to be checked for e antigen. Positive e antigen indicates a higher risk of transmission to the baby, not just the DNA level. It's a very nice algorithm. I'm not going to walk through everything here, but I just want to point you to that we've got this algorithm that takes place. Now, this is interesting because in this algorithm, they talk about a cutoff of 1 million, and what I've already talked about before was 200,000 of level of virus in the blood. That's a more common number, although some people have used the 1 million value as well. And this really does decrease transmission. This can take it down close to 0 if we follow this protocol. Let's talk about pregnancy on hepatitis B. After the mother delivers, the immune system ramps up, can start fighting the virus and the mother go through this interaction where the enzymes go sky high, the bilirubin may go abnormal as well. And potentially, if the mother's got advanced fibrosis or early cirrhosis, the mother could go into liver failure. So after delivery, the mother needs to be monitored with blood tests. I usually recommend monthly for 3 months and then every 3 months to wrap up that year. This is a number of papers about flares. When we talk about flares, that means the enzymes are going up. In a subset of those patients, you can actually have abnormal function. So look at the number of flares that can take place in these pregnancies, and it could be up to 50% have flares. And that's scary for the mom. We, as providers, get very concerned. This is management of hepatitis B. I think we've covered everything here. Let me see if there's anything missing. It's just another good algorithm. And this just highlights antiviral therapy options, but preferred during pregnancy is going to be TDF, but TAF, there's a really good paper that just came out showing very effective viral transmission prevention with TAF or Vemlidy, and that will eventually make it into the guidelines, I believe. Impact of hepatitis B on pregnancy outcomes. So this is kind of the reverse situation. What happens to the virus and the effect on the mother? This can result in preterm birth, can result in the mother developing diabetes, can result in the baby having a lower birth rate. And if the mother has HIV, you can transmit HIV and hepatitis B or HIV and hepatitis C together. After the baby is delivered, you got to monitor that mom. We talked about monitoring liver enzymes, monitoring liver function. You're going to go back and make sure the rest of the family's been tested. If the mother's had any other children, you're going to test those children for hepatitis B. There are some discussions about if the mother comes in on, say, Tenofovir and she's pregnant and she's already 2 to 3 months into her pregnancy, do you stop the TDF? And it looks like from the HIV literature that TDF is safe throughout pregnancy. But we talked about starting it at week 28, but there is a decision process, an educational process that can take place between the provider and the mother about if the mother's on Tenofovir, TDF specifically, you can continue that during the pregnancy. Breastfeeding is okay, not contraindicated. It's kind of a double negative. There's very little antiviral, very little virus in breast milk. And the mother, if she had breakdown of skin and the baby had breakdown of skin in the baby's mouth or the teeth or gums, there's this theoretical risk of transmission, but this is extremely rare. And the TDF is very safe from a breastfeeding perspective. So to wrap up hepatitis B, just remember there are supportive services out there. There are barriers. It could be language, income, transportation, proficiency. Stigma is a huge issue. And stigma is an important issue because eventually we're going to treat every patient who's surface antigen positive. We need much more effective therapies and a good safety and cost profile, but that's where we will be eventually. There's immigration issues, other assistance that may need to take place, including medication support. You're going to counsel them about adherence, risk of flares, risk of transmission. It's an infectious disease. It's a systemic disease. And there's treatment access that's listed here about how to get medications if there's challenges financially or insurance. Okay, we're going to move on to hepatitis C. We're well into our presentation. I focus heavily on hepatitis B because that really is the biggest problem globally. But hepatitis C can pose a problem to the mom, and it can be transmitted to babies. And there's, with this IV drug use, opioid epidemic that we're having in parallel with the COVID-19 pandemic, there's an increase in the amount of hepatitis C among pregnant women. This is 2014 data, but it's gone up substantially. This is also blood to blood. You don't get hepatitis C by holding hands, kissing, silverware, dishes, glasses, utensils. It's rarely transmitted sexually. Hepatitis B is much more infectious from sexual transmission exposure than hepatitis C. Blood exposure, including dental work, unsterile vaccination or procedures or tattoos. We quote a 2% risk of the mother transmitting this to the baby. And then of the baby who's develop hepatitis C, 25 to 50% of those babies will clear hepatitis C. When you say clear C, this is a cure of C. It's a true cure. You prove people have hepatitis C through a two-step process: antibody. If that's positive, it means exposure. RNA being positive, that means they're actively infected, and you must get a quantification back. Qualitative hepatitis C RNA by PCR is out of date and should not be used. Hepatitis C during pregnancy is very unlikely to progress to severe liver failure, although there is a slight chance, and of course you must stage the mother for the level of her liver disease. This is a curve about hepatitis C in childbearing age, and you're already seeing an increase here as far back as 2013 and 2014. This is going to be higher now. Why might women be at higher risk for hepatitis C? Because there is injection drug use that takes place, needle sharing, syringes that are all shared, unfortunately, here. Now we're up to 2017 with this increase, and this is definitely a disease that's much, much more in the Caucasian population. You're going to test all adults for hepatitis C. You're going to test all pregnant individuals for hepatitis C. This just has to do with the task force recommendation and just the general screening that takes place. So we now say all adults need screening for HIV. All adults need screening for hepatitis C. I'm hoping soon we'll screen all adults for hepatitis B, not too far away. A little bit more information that's taking place, all pregnancies. It's just clear from all organizations who are collaborating in this space. This is clearly cost effective, and now with the prices of our hepatitis C drugs, in that 17,000 to 24,000 for an 8 or 12-week treatment interval, this is not just cost savings. This is this is not just cost effective. This is cost savings. So if you put in $1, in 5 years you get $1.20 back. And that just is a rare thing in medicine. You're going to monitor enzymes and function during pregnancy. I disagree with the terminology AASLD is using, routine liver function test. What they mean is routine liver enzymes. And you're going to, of course, get prenatal care. We don't treat hepatitis C during pregnancy like we talked about with hepatitis B, even though it looks from some recent data that the hepatitis C medicines that we use would be safe during pregnancy. But because the transmission rate to the babies in the 2% range, there's really not a need to treat 100 women to prevent 2 transmissions, because now we have hepatitis C medications, our 2 leading medications, Mavorette and Epclusa, that were just approved in the last 2 weeks down to an age of 3 years. So that's fantastic news. So the child is not going to develop cancer of the liver, cirrhosis, or need a transplant between birth and 3 years of age. We can treat at 3 years. Just like hepatitis B, hepatitis C can change the preterm birth timing, fetal growth, and in terms of the timing of the birth, causing an increased risk of preterm deliveries. So this is very, very important to be thinking about that. And there is a increased risk of late neonatal death, which is very sad. We're not sure how that interaction takes place, but these are important numbers. We talked about a Swedish study on the last slide. So there's this intrahepatic cholestasis of pregnancy, this itching. So hepatitis C looks like it can stimulate that itching process during pregnancy as well. You really want to treat while there's pregnancy planning, childhood or delivery planning that's taking place. You're definitely never going to give ribavirin to a woman who's thinking about getting pregnant. Never going to give it during pregnancy. This is a class X, I think, carcinogen or teratogen, I guess is the most important thing to say here, teratogen. So you're going to wait until 6 months after completion of ribavirin therapy to get pregnant. You just don't have data about treating during pregnancy, so there's some statements about that here. So that's just, we're not going to be recommending that. Theoretically, you cure the mom, you're going to decrease the risk of transmission, but why not just wait for the baby to be born, get the 3 years of age, and then get treated? This is about HIV interacting with hepatitis C. So if the mother is HIV positive, there's a higher risk of hepatitis C transmission. Can you block transmission? That looks like the level of evidence is quite low that you're going to prevent transmission because the transmission rate is so low. Breastfeeding, no association, so we think that's also a safe process to do. Amniocentesis possibly could increase the risk of transmitting hepatitis C from the mother to the baby. And cesarean sections does not decrease the risk of transmission. It looks even between C-section and vaginal delivery, which is kind of interesting because baby comes out in this, enveloped and protected, but the C-section potentially could be traumatic to that protective element for the baby. In children, mother-to-child transmission is the most common cause, although it's rare. We mentioned that a lot of the infants, close to half the infants, will clear in hepatitis C in less than 3 years. So that's why you tested 3 years, and then if their baby is hepatitis C RNA positive, we have 2 excellent medications that are going to be resulting in an extremely high cure rate. In those pediatric or childhood studies with hepatitis C, the cure rate was in the 95% range. There is a risk of cirrhosis in children who acquire hepatitis C, but that cirrhosis is going to be discovered 5, 10, 15 years of age. Let's treat at age 3 if they're infected. You're going to screen the babies, of course. Strong recommendation. Antibodies, your first test. The baby, a child is antibody positive. You're going to check RNA. But are we testing children? I'm not going to go into this great detail, but the problem is the follow-up of these children is just really, really terrible. So we had 8,000 women in this registry, and there was births, 568 births to hepatitis C positive mothers. Of the eligible infants, 537, only 84 were tested. It's so sad. So treatment of children, we got this new 3-year age, and of course, if there's extrahepatic manifestations, you're going to look for extrahepatic disease in hepatitis C in those neonates and children. These drugs do look safe. They really should be category B across the board, in my opinion. Blood soft during pregnancy, there's this one study that was done, very, very small number of individuals that were, and this is an open label study, and this pregnant individuals, there were only 9 in this. I don't know if this was an abstract. I don't know if this actually got published. To look at this. And it says Lancet Microbes, so it must have been published eventually. But look at this very, very high clearance rate. very, very good numbers. So hepatitis C among women of childbearing age during pregnancy has been increased during this opioid epidemic that we have here. Recommend screening all pregnant women, all pregnancies, as I said before, a little redundant. Really want to get that treatment before pregnancy and then wait a few weeks just to be absolutely safe before they start trying to have conception. Whether it's a child transmission, there have been some studies as high as 11%. I quote 2%, although knowing the number may be in the 6% range, I think maximum. Treatment at age 3, we talked about, and lots of great changes. We've gone from 10 to 20% to 50%, 70%, 95%, and now in children, we're seeing that 95% too. Very rare to have any side effects. Mothers, I think, should be co-managed with a liver disease specialist, whether that's infectious disease, gastro, or hepatology. I think that's very important. Breastfeeding is safe. Pregnancy testing. Well, I think we've covered everything here. Covered this. Let's now wrap things up. Another 2 diseases I'm going to mention are herpes simplex and hepatitis E. Hepatitis E is much more common in the Middle East, Asia, Central Asia, the Indian subcontinent. Herpes has been seen, of course, you take a herpes history in the mother during the pre-pregnancy visit, come in pregnant. It can be treated with IV acyclovir. It does not require delivery. It's typically more common in the 3rd trimester. They're usually febrile, often with a rash, really feel weak, big swollen liver, right upper quadrant pain. Enzymes can be in the 1,000 range. Bilirubin can go up also. CT scan, if you're going to do that during pregnancy, which is going to be unlikely because of radiation, but could show a lot of non-enhancing areas in the liver. So if you did this, you'd use ultrasound first, MR second, try not to do CT scans. Maternal mortality is very high without acyclovir treatment. Transmission to babies is very substantial, 33 to 50%. This liver looks swollen, looks sick, looks mottled, heterogeneous. Left upper part of the slides, the liver. Clinical outcomes, never going to be chronic. If you manage it early, the mother can take the pregnancy to full term, but there is a risk of chronic disease in immunosuppressed individuals, HIV, post-transplant, chemo, and that is also seen in hepatitis E. Oh, actually, this should say hepatitis E at the top, not HSV. I'll fix that. Thank you. A little bit more in hepatitis E. It's rarely seen of this acute liver injury. There are almost 600 cases, but very few of those were positive. And the ones that showed IgM, which was 3, they all recovered. So it should be tested for hepatitis E IgM. That's the best test for acute hepatitis E. HEV hospitalization. This is a national inpatient sample database that took place, published in Hepatology. In good management, here the mortality rate was only about 2%. Of course, all deaths are bad, but that is the typical number that we think about. Hepatitis E can cause acute on chronic, so the mother's got alcoholic liver disease or fatty liver cirrhosis. It gets acute E. Really can get severe liver failure in these patients. More and more hepatitis E in Europe. I'm not showing the US data, but hepatitis E is falling. Hepatitis E is transmitted by dirty water, fecal oral transmission. It's very rare to be transmitted by any other system. We have a great country with very clean water, so it's very unlikely this would be introduced into our environment. There are 2 vaccines for hepatitis E, but the main one is sold in China, not available outside China that I know about. Hepatitis E is transmitted by dirty food, pork, ham, things along those lines. This is an example of one that was a commercial one. One of the biggest issues, if the mother gets hepatitis E, the chance of her dying is very, very high. And that's why hepatitis E needs to be managed expectantly and, of course, ultimately prevented to try to decrease this risk of mortality. So hepatitis E in a regular person who gets ill is not pregnant, the chance of dying from hepatitis E is far under 1%. But in mothers with hepatitis C, it's up to 26%. So to wrap things up, all mothers, all pregnant individuals need to be tested with liver enzymes and function. If the enzymes and or function are elevated or abnormal, a thorough workup needs to take place. This is not something that needs to be ignored. Take a good history. Is there underlying liver disease? Is there a risk for underlying liver disease? And in special cases, we talk about herpes, high fever, big swollen liver. The mother has got a history of herpes simplex. That workup needs to take place expediently. Mother needs to be placed on Acyclovir or equivalent. I could also use Valgan Cyclovir, but that would be evaluated. I think that's a wrap. I'll give it back to Shirley, and maybe Terry can answer a couple of questions about San Diego public health.
Thank you so much, Dr. Gish. That was a wonderful, comprehensive survey of pregnancy and viral hepatitis. I had a couple questions. I was actually surprised at that mortality data with hepatitis E. So given that it is kind of a 26% mortality risk with hepatitis E, do you recommend that pregnant women get tested for hepatitis E, or maybe based on specific symptoms? What would you suggest?
Any mother with acute liver enzyme elevation should have a hepatitis E IgM test done. Yes, and when you have acute rise, you're going to work up for hepatitis A with IgM, hepatitis B panel, including an IgM core, hepatitis C antibody, hepatitis E IgM. That's the big 4 tests that you would do.
Great. And then just, since our webinars are geared towards patients and their caregivers, I was wondering if you could answer the question of if a patient who knows that they have had hepatitis B in the past and they find themselves pregnant, what type of provider would you recommend that they seek?
Well, you asked it in a very good, clear way. So if they have a history of hepatitis B, but if they've cleared surface antigen, they can just get regular, follow-up. But if they have surface antigen, hepatitis B surface antigen positive, that individual, whoever that OB is, needs to consult with a gastroenterologist or infectious disease or hepatologist to co-manage that patient during pregnancy.
Great.